Today's lecture will be on the elbow complex. Review your bony anatomy of the ulna bone. It will be important for when we are palpating to take measurements for goniometry, also as a reminder of muscle attachments. Also review the bony landmarks on the radius and the muscle attachments to each of those areas. This picture reviews the placement or the location of the ligaments of the elbow. The annular ligament that goes around the radial head, and then both the lateral and medial collateral ligaments. In class, we will perform special tests, both a varus and a valgus stress test, to test the stability of these ligaments. Here you see the joints of the elbow. The humeral ulnar and the humeral radial joints together make a modified hinge joint of the elbow that has 1 degree of freedom or 1 degree of motion of flexion and extension in the sagittal plane. And then the proximal radial ulnar joint is where the supination and pronation occur. All 3 joints are encapsulated in the same joint capsule. So if we talk about the arthrokinematics of, if we say the elbow joint, we're talking about mainly the humeral ulnar joint. We're going to say that we have concave surface moving on convex. So when we have concave on convex, we know that the roll and the glide is in the same direction. So if we are going to move into elbow flexion, the roll and the glide are both anterior, and then extension be posterior. So a joint mobilization to improve elbow flexion would be an anterior glide. This is the olecranon bursa, which is at the elbow joint to reduce friction. It often becomes inflamed and weight-bearing and has the name of student's elbow when it becomes inflamed and swollen from students leaning on their elbows on their desks. Please review these videos that I have placed on Blackboard under Module 1. One of the videos is going to be a review of the musculature of the forearm, and the other video is going to show you the motion of pronation, supination in comparison to shoulder internal and external rotation. This slide reviews the anatomy of the biceps brachii muscle. And again, this muscle has actions both at the shoulder and the elbow for flexion because the long head of the biceps crosses both joints. This slide is a review of the triceps muscle with its origins and insertions and its action on both the shoulder and elbow into extension. Please review the muscles of the elbow and forearm. We will be testing manual muscle tests in muscle groups as well as distinguishing between individual muscles. For example, we will test a muscle test for biceps brachii and a different test for brachioradialis. So please review. We will now review some common conditions of the elbow and the clinical practice. Osteochondritis dissecans is a fairly uncommon condition but can be seen in both the knee and the elbow. It occurs when a piece of subchondral bone separates, usually due to a lack of blood supply, where avascular necrosis occurs or where bone death occurs. It is commonly seen in older adolescent males and may be a result of trauma or can even be repetitive stress or overuse, as seen in the pictures of throwing or weight-bearing in handstand. It is usually asymptomatic unless that bone fragment separates. In that case, it can come loose within the joint space and cause it to lock up or have that hard end field that is abnormal, could cause irritation and pain to the structures within the joint. Clinical management: if the bone fragment is free floating within the joint space, surgery will need to occur to remove it. And then treating after that will be treating for inflammation, controlling edema using our modalities, and then improving range of motion and strength as tolerated. If the bone fragment is not detached, then it is going to be a time period where there will be a lot of education to promote non-weight bearing to allow for healing, and then progress with range of motion and strengthening. Medial and lateral epicondylitis, also known as golfer's elbow and tennis elbow, are an inflammation of either the wrist extensors or flexors. Usually these occur from repetitive injury or repetitive overuse, a lot of times with recreational as well as work activities. So with lateral epicondylitis, it is the overuse or stress of the wrist extensors, and that is where the group of wrist extensors originate, is at the lateral epicondyle. Patients who have this will have pain to palpation right over that area where the tendons insert, and will have pain with any type of gripping activity, because in order to maintain a functional grip, our wrist is in slight extension. And then the golfer's elbow or medial epicondylitis is the attachment of the wrist flexors, and will have pain to palpate over that area as it is inflamed. The clinical management is going to be relative rest. I see that in quotations. It doesn't mean that you immobilize this patient, but you try to change whatever that activity is that is causing the inflammation. If it is coming from playing tennis, then trying to get that patient to decrease the amount of times they're playing tennis, or truly to give it a rest for a couple of weeks, which can be sometimes a very hard sell. Or if it's relating to a patient's livelihood, they may not be able to truly let it rest. In that case too, using some of those, you may have seen a counterforce armband where it's a strap that goes right around the muscle tendons to kind of decrease or disperse the forces and stress in that area might be needed. In therapy, we will do modalities that's going to decrease the inflammation. If you can even think back to the first semester, this was the diagnosis that we did for using ice massage. So you should be quite aware with that. Physicians will probably prescribe NSAIDs, or they may do an injection depending on how long or how severe the inflammation is. You can do joint mobilizations. We're going to do isometric contractions and progress to all strengthening of all the muscles, as well as doing a good stretching program. And this will be something that you'll want to encourage your patients when they return back to activity or sport, that they do a nice warm up and then really do some stretching before and after their activity. Medial valgus stress overload at the elbow usually occurs in patients who have a repetitive throwing or racket sports, where they're putting repetitive stress on the ulnar or medial collateral ligament of the elbow. Signs and symptoms that they will experience is that they will have medial elbow pain, slightly even posterior, and that they would probably have a positive valgus stress test, which is the special test we will do in lab. Clinical management of this is, again, if there's the inflammation and stress on the ligament, is going to be education, trying to get that patient to rest from the activity or modify the activity that they are performing. You also are going to want to do modalities that are going to decrease that inflammation. Again, the physician may have prescribed pain meds or anti-inflammatories. Again, further education just to avoid stress on this ligament. And then you will be just doing some gentle stretching of all motions and strengthening at the wrist, hand, and shoulder to try to strengthen the function of that arm, so that maybe that ligament isn't going to take stress when this patient returns back to their activity. Sometimes, if it is quite involved, there might need to be a surgical intervention. If that is the case, then you will follow the protocol following the surgery. Elbow fractures are fractures of either the humerus, radius, or ulna, and usually result secondary to trauma. At the humerus, we can have a supracondylar fracture, which means it's above the condyles, or as you see the picture on this slide, an intracondylar fracture, radial head, or the olecranon. Dislocation and soft tissue damage are often occur with an elbow fracture. Medical management, if we look at the types of the elbow intracondylar fracture, when a fracture is non-displaced, usually the fracture will be treated with immobilization. But once displacement has occurred, the patient's going to require surgery and an open reduction internal fixation. When people are immobilized and casted, as a PTA, you want to educate the patient to move the joints above and below to prevent any loss of motion, and to also educate them on vascular supplies. So as you see listed there, the Volkmann ischemic contracture, which can be a complication more often of the supracondylar fracture, but can have where they're going to have a decreased blood supply to the forearm. So that patient would have pain in their forearm while they're casted. You might see a purplish tint to their fingers, and that tingling sensation as well. Further clinical management, once the immobilization or the cast has been removed, we're going to work on active range of motion and gentle stretching of the elbow. Don't necessarily want to do that passive prolonged stretch and put that too much stretch on the newly healed joint. We will be doing strengthening and progressive strengthening. Joint mobilizations are listed there as a possibility, but you want to make sure that that bone is healed. And that would have to be through radiograph, and have that as a goal specifically written by the PT to perform joint mobilizations. This could be a long recovery, especially for this area. A lot of times they have complications and may not get the full range of motion in the elbow, and so they may be in our rehab or with us in physical therapy for 3 to 4 months.
In lab, we will be practicing goniometry and manual muscle testing of the elbow, as well as reviewing treatment plans for improving strength and flexibility at this joint.